In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
Hoy es un día muy esperado para todos los integrantes de la Asociación Buena Vida, porque celebramos la cura de varios pacientes de hepatitis C. Nosotros en nuestro grupo decimos que vivir con el virus de hepatitis C es sentir que uno tiene una bomba de tiempo dentro de uno y que no sabe cuándo va a explotar. La cura significa desactivar esa bomba. Por eso estamos todos juntos hoy para festejarlo, entregar las remeras con la inscripción de hepatitis C curado, y ese es el momento cúlmine de nuestra labor como voluntarios de la Asociación Buena Vida.
Soy Raúl y estoy curado.
Soy Majo, estoy curada.
Soy González Julio y estoy curado.
Hola, soy Susana y estoy curada.
Soy José Luis y estoy curado.
Soy Graciela y estoy curada.
Soy Adrián y estoy curado.
Soy Andrés y estoy curado. Hola, soy Miguel y estoy curado.
Hola, soy Gabriel y estoy curado.
Soy Carlos y estoy curado.
Soy Nelly y estoy curada.
Soy Claudio, estoy curado.
Soy Rubén y estoy curado.
The doctor told me that, look, you have hepatitis B, so you cannot go overseas. No one at all from my village had that opportunity to go overseas for study. And for sure, my parents would not be able to afford any of that. So having a scholarship to study overseas is actually a really big deal for someone from a village in the north of Vietnam. And I was lucky enough to secure a scholarship to study in Europe. And as a part of the paperwork, I have to go through a health check, and hepatitis B test is among the health check. So when I came to get the result, the doctor told me that, look, you have hepatitis B, so you cannot go overseas. And then I had to reject the scholarship just because he told me so. I don't know why, by that time I didn't challenge him or explore more, whether what he said was correct. But look, as a first year university student and you had no experience in life, and then you tend to trust everyone that deemed to be more superior than you, like the doctor in the hospital. Hello everyone, welcome to our session, Hepatitis-free generation, preventing mother-to-child transmission. So in this session, we will focus on describing the global burden of mother-to-child transmission of hepatitis B and gaps in antenatal screening, treatment, and infant vaccination. And we also look at global birth dose coverage and the implementation challenges to birth dose, which will be addressed in different settings. And also the experience of mothers living with viral hepatitis and the challenges they face in accessing services for themselves and their infants will be recognized as well. So I highly acknowledge that some of us are joining really early in the morning, like 4 or 5 a.m. and some people in the better time zone, like we are here in Geneva, and I know some people are joining at midnight. So thank you very much for your dedication and your enthusiastic for the session. So that's so. So now I want to hand over to my co-chair, Dr. Moko Newman. She will introduce herself and then we'll give her talk about GVAC.
Thank you very much, Leanne, and greetings to everyone as well, as Leanne said. And I am actually working WHO. I'm the co-chair here, and I lead the triple elimination agenda in the WHO hepatitis, HIV, and STI program. So just before we start, we'll give you a little background on the GVAC. More than 10 years ago, the global health community committed to elimination of vertical transmission of HIV and syphilis, and this was based on evidence that this was actually feasible. Advocacy, now we know, to achieve elimination of these pediatric infections is really key and very critical. Countries enthusiastically responded to the call to action and requested that WHO develop criteria and targets to measure progress and help define and recognize the achievement of the agreed on targets. Many of you are aware of these targets. The Global Advisory Committee, the GVAC, was then formed and had its first advisory meeting in 2015. And this meeting was where Cuba was the first country which got validated. Now, the Global Advisory Committee consists of 25 independent experts in the areas of PMTCT of HIV, syphilis, and hepatitis. And this also includes expertise in laboratory, human rights, gender equality, and community engagement. In 2021, 4 new experts were joined the GVAC, and they provide the expertise in PMTCT of hepatitis B, which includes immunization. So the GVAC is now ready and waiting to receive applications for PMTCT of hepatitis B, noting that applications for triple elimination will go through both regional and global review, whereas the single applications for only PMTCT of hepatitis B goes only for regional review. So a country which has been validated for triple elimination, any country, the GVAC continues to consider whether that country is sustaining elimination at maintenance. And for triple elimination, this will be every 6 years. So on that note, I would next like to introduce our next speaker, who will be talking about the urgency and necessity of PMTCT in achieving hepatitis elimination. And I'd like to call on Dr. Fumi Leshi, who is the lead for the Global Hepatitis Program here in HQ. And Fumi, please go ahead.
Can you see my screen? Hi, Moko, can you see my screen? Can you hear me?
Yes, we hear you.
Okay, thank you very much. Thank you very much for introducing us to GVAC. Moko, my name is Fumi Leshi. I'm the viral hepatitis lead here at WHO HQ in the Department of Hepatitis, HIV and STI. And my topic is the urgency and the necessity of PMTCT in achieving hepatitis elimination. Okay. Sorry. I'm trying to move my next slide. Doesn't seem to be moving. Okay. So the question is, do we really think it's necessary? Do we think it's urgent? And I'm going to show some data, and it'll be great to see what you think, if it's necessary and urgent. If you look at the burden of hepatitis B and C, we're talking about 30 million infections globally. In 2020, we had 3 million new HCV and HBV infections. We had 1.1 million deaths from liver cancer and liver cirrhosis. This means that there were 3,000 people dying every day. I think that makes it necessary and that makes it important. Furthermore, we have a global strategy in 2015 with the goal of eliminating viral hepatitis as a public health threat. And this strategy calls for reducing the incidence of new infections to 90% by 2030, from 6 to 10 million infections in 2015 to less than 1 million infections in 2030. We have identified 5 important interventions that will take us to elimination. That is the prevention of mother-to-child transmission and infant vaccination. We even have the tools for validation being prepared. We're looking at option A from our validation framework that serves for hepatitis B PMTCT elimination and measuring achievement and attainment of that target with recognition from WHO, recognition for progress made, recognitions for attaining the targets. This is a very familiar slide. We know about this slide. So we have the vaccines that have reduced the incidence from before the 2020s, or actually started early in the 1990s. And in the year 2020, we reached the SDG achievement of hepatitis B prevalence in children under 5 of less than 1%. And that was a major milestone. But there remains pockets of infection. And doing a quick analysis of these countries, we see where they are in different regions of the world. So I think the answer again is yes, we have a strategy which has now been renewed for 2020, 2030. We have the diagnostic tools, we have the vaccines, we have the treatment to prevent people dying daily, we have the cure for hepatitis C infection. Yes, I would agree completely that it is necessary and that it is timely. So what do we need to do to chart the course to elimination of PMTCT? One of the important things that we need, the data and innovation. These matter. This study was done in 2016, and already it shows that this study evaluated different approaches to reaching 2030 elimination using modeling studies. It shows what we know very well, that childhood vaccination is the cornerstone of elimination. It also shows an optimal approach as a combination of vaccination and other mother-to-child interventions, including an ambitious population-wide testing and treatment are needed to eliminate hepatitis B infection and even C for hepatitis C treatment. We looked at service delivery and data from service delivery showing us that innovation matters. And we'll just quickly look through some of the data from DRC and Mozambique that shows that triple elimination within pre-existing HIV PMTCT programs are very important. And the elimination pilots show us that countries have the systems to measure progress. The second, what matters is context. Context matters. This chart shows different prevalence in different regions. You see Afro with the region of a high prevalence, where 70% of new infections occur, and you see Europe with a low prevalence, with a minority of new infections. We also look at this very well-known tiered approach the incremental approach to prevention, talking about vaccination as the cornerstone. And at that tip, we're talking about treatment of mothers. So context matters. For example, if you look at this study that was published, that was presented at EASL, it shows that in UK, with a low prevalence, selective antiviral therapy or selective burst dose policy in this low prevalence population can successfully lead to elimination. So that may not be the same for high prevalence areas like Africa. Programs and health systems matter. Look at the operational considerations for infants, for mothers, issues of financing, interventions, workforce, testing, and data are important. If we look at this report on service delivery, which was done from DRC, shows that antenatal hepatitis B testing and antiviral prophylaxis, as well as birth dose, is feasible and acceptable using pre-existing HIV platforms. And it lists a whole host of challenges that they faced in reaching that. Again, I'm trying to move my slide, it's not moving. Okay, so will scaling up childhood vaccination and hepatitis B birth dose get us to option A, certification or gold status? Maybe. Political will also matters. Okay, political will and community matters. The political will set the stage for an enabling environment and mobilize resources for reaching elimination. And if we look quickly at the next steps on the journey to 2030, the new global strategy is very important, with the key strategic shifts using lessons learned from COVID with coordinated and joint management approaches, and upcoming WHO guidance on hepatitis B, hepatitis C, and even validation of elimination. And on that note, I say thank you very much, Moko, for the opportunity to present. And I agree, we all agree that it is important, it is necessary. We have everything we need, the strategies, the tool. We need some political will to go for gold and to go for option 3. Thank you very much. And over.
Thank you very much, Funmi, for the overview. I think that's great to know that like the policy and the guidelines are in place. It's just a matter now how we implement, how we overcome all the challenges to make sure that we prevent, we deliver the best services for women and the children. So I just want to remind people, if you have any questions, please put that in the chat, and we'll go back to the questions at the end after all the presentations have been delivered. We actually have time for Q&A, so we'll have time. So with no other delay, I want to introduce our next speaker. So I want to introduce Jualina Roberto Tibana from the Ministry of Health in Mozambique. And she can talk about Médecins Sans Frontières PMTCT work in Mozambique. So Jualina is a general physician. I don't know why it's a bit it's not that late, but it's late in Australia for me. So she has been through a lot of different positions in the health system in Mozambique and with other health organizations as well. And in her current position since March 2018, she works at the Ministry of Health of Mozambique as a PMTCT Senior Advisor at the National STI HIV/AIDS Program. So the floor is yours, Paulina.
Okay, I will be speaking about PMTCT for hepatitis B virus in antenatal care and maternity services in Mozambique with support of Medicines Sans Frontières. So moving to my next slide, in terms of prevalence of hepatitis B virus in the general population in Mozambique, it is estimated that the prevalence is 7.2% in the general population. And in the graph below, which disaggregates the prevalence by sex and age, we can see that the prevalence is higher among adult males compared to females. And we also have other studies that were carried out within the country looking into specific populations, where we have an estimated prevalence of hepatitis B surface antigen of 4.5% in women who are blood donors and 12.2% in young adults co-infected with HIV. So the rationale for the implementation of this project in Mozambique is the fact that the country is a low and middle income country with high transmission for hepatitis B virus. There are patients who need hepatitis B treatment following WHO recommendations, but are not receiving it because of lack of local evidence, clinical guidance, and consumables for diagnosis and treatment. The hepatitis B vaccine birth dose is not yet included in the national immunization schedule. So in 2017, MSF proposed an intervention using the WHO recommendations to develop a feasible model of care, which was integrated in the maternal and child health service as one-stop shop for PMTCT for hepatitis B. So this project took place in Shamankulu Hospital in Maputo City, and the activities mainly were hepatitis B testing, which was integrated with HIV and syphilis testing in antenatal care services and was done by maternal and child health nurses. Hepatitis B treatment and prophylaxis for pregnant women who need it, vaccination of the newborn within 24 hours of birth before discharge from maternity, and offer, and for those women who are hepatitis B surface antigen positive, a test was offered to the partners and their children, and also vaccination if they were found to be negative. So the integration of hepatitis B virus activities was into the routine PMTCT workflow was crucial to ensure the sustainability. So this diagram, it shows the flow and interventions for pregnant women in antenatal care and maternity unit in Shamankulu Hospital between 2017 and 2019. And of the 6,700 women, 775 women who were screened for hepatitis B surface antigen, 270, so 4% were found to be positive, and the other 6,500 who were negative received hepatitis B virus vaccine. For the management of the women who were positive, tenofovir was used. So we had 2 women who were eligible for both HPV treatment and PMTCT, 2 women who were eligible for HPV treatment only, 4 who were eligible for HPV PMTCT, and we had 98 women who were already on tenofovir regimen as part of the ART treatment because they were co-infected with HIV. And we had some losses along the antenatal care cascade. So 47 women were lost to follow-up, and 3 women were also stopped for other reasons. So in the end, we had 220 women who gave birth to 224 babies. Of these babies, 7 were stillborn, So in the end, we had 217 live burns, of which 23.4% received HPV birth dose vaccination on contact. Again, along the cascade of care for mother and baby pair, we had losses. And in the end, we had 134 babies who completed the follow-up. And if we look at the final status of the baby, we can see that 133 were negative at HPV surface antigen testing at 9 months. And only one was positive, and this positive was the one that didn't receive the birth dose vaccine. In terms of social demographic data of the woman who tested positive for surface antigen, 98 women were co-infected with HIV, and also of those 270, 191, so 70.7% presented to their first antenatal care when they were already in the second trimester of gestation. In terms of biological characteristics, 24 of the women who screened positive for surface antigen also screened positive for E antigen. 14 had a HPV viral load that was higher than 200,000. One had an APRI score that was above 2, and ALT that was above 40 international units. And in terms of co-infection,
we actually we are really short in time. So if you can go a bit quickly, and if you can wrap up in 30 seconds, that'll be great. Thank you.
Okay, thank you. So in terms of conclusions, we had the feasibility of a nurse-led one-step intervention providing HPV-free PMTCT, including the birth dose. The activities, they can be integrated in pre-existing screening programs, and the birth dose vaccination was found to be key for achieving the 2030 target of elimination. In terms of strategic framework, we have 2 guidelines in the country. So we have the Hepatitis B screening prevention guideline, which has information regarding screening and treating for hepatitis B for pregnant women. And we also have our triple elimination plan, which was developed in 2020 and 2024, which also has information regarding PMTCT of hepatitis B. The currents that we're facing now regarding implementation at national level is that the rapid diagnostic tests of surface antigen are not yet available, but in the process of procurement with support of Global Fund. Also, the hepatitis B birth dose vaccine is not yet available in the public health system, and the lack of a monitoring and evaluation system that can help monitor the implementation of hepatitis B PMTCT nationwide is also not available up to now. So, in terms of next steps, we will follow up with Global Fund grant for the acquisition of the rapid tests and the acquisition of TDF for prophylaxis. We have already developed the plan for introduction of the birth dose vaccine in the country, but it's still pending the MOH validation. But there is willingness for mobilization of domestic funds to purchase the vaccine. And we have also developed the national clinical protocols for the implementation of the hepatitis B, and still pending just the TOT, and we are also working already on the monitoring and evaluation tools to capture and the indicators and variables to complement the clinical package. Thank you very much.
Thank you very much, Kwalila. And you've actually shown us that integration works, which is great, and that the MCH platform is ready and capable of taking up with the systems in place and extending not just care for the mother and the child, but also to the whole family. So thanks very much for your presentation. I next would like to introduce our next speaker, who is Devin Razavi Shearer. And Devin has led the Hepatitis B and Delta project since the inception at the Center for Disease Analysis Foundation, and this has been since 2015. He also led previous work in Vaccine Impact Modeling Consortium, which now models the impact of vaccination for Gavi. So Devin, please go ahead with your presentation, which is on CDA analysis of birth dose coverage in Gavi versus non-Gavi countries. Thank you.
Hello, everyone. My name is Devin Razavi Shearer, and it's truly a pleasure and a privilege to be with you all here virtually. I'm from the Center for Disease Analysis Foundation, and today I'll be talking to you about the impact of hepatitis B vaccination programs in Gavi countries versus non-Gavi countries. So to examine these differences, what we did is we utilized the 167 country-level models the Polaris Observatory maintains and updates annually to estimate the chronic perinatal incidence of hepatitis B in 1985 and 2022. So we looked at 4 groups of countries. We looked at the global level, just to get an idea of the global averages and trends. We looked at non-Gavi countries, so countries that do not currently receive pentavalent support from Gavi. Then we looked at Gavi birth dose countries, Gavi BD. These are countries that currently receive the pentavalent support from Gavi, but also on their own have implemented timely birth dose coverage at levels of 50% or greater. Lastly, we looked at non-BD Gavi countries. So those countries who receive Gavi support for pentavalent vaccination, but have levels less than or equal to 50% of timely birth dose coverage. So what we found is that currently there's about 23 countries who receive Gavi support for pentavalent vaccination that also have birth dose levels of 50%, greater than 50%. 13 of those are what once was called the Second World, and 7 of those were from the former Soviet Union. This is noted because we know that former Soviet states tend to have very robust vaccination programs, and many of these countries in the Second World have a strong commitment to public health. Only 3 of these countries were from Africa. Guyana was the only country that was representing the Americas, and the remaining 6 were from Asia and Oceania. So what we found is, of course, as expected, as vaccination programs have greatly reduced the incidence of chronic hepatitis B infections perinatally per 100,000. So globally, we estimate that between 1985 and 2022, cases dropped by 83%. Now in non-Gavi countries, there was a 95% decrease in this rate. For Gavi birth dose countries, we estimate an 89% reduction. And of course, the lowest decline was unfortunately in the non-birth dose Gavi countries that only saw a 71% drop between 1985 and 2022. Now, another way we can look at this data is to examine the trends in the disparities in these rates of chronic hepatitis B perinatal infections. So if we look here on the left, in 1985, what we see is that at that point in time, non-Gavi birth dose countries had 1.8 times the rate of chronic infections as did the global average. It was 2.4 times higher than that in non-Gavi countries and 1.7 times higher than Gavi birth dose countries. So we're starting with baseline disparities. Now, unfortunately, these disparities have not only persisted, but they have greatly increased. So here on the right, you see that in 2022, now non-birth dose Gavi countries have 3.3 times the global rate of hepatitis B perinatal chronic infections, 14 times the rate of non-Gavi countries, which is truly astonishing, and then 4.4 times the rate in Gavi birth dose countries, which is also high. So we've seen a widening in these disparities, even though overall these rates have dropped substantially. Now, globally, the absolute number of perinatal infections has also decreased quite a bit. So we've seen this 73% reduction between 1985 and 2022 at the global level. We estimate a 93% reduction in non-Gavi countries, an 81% reduction in Gavi birth dose countries, but only a 27% reduction in non-birth dose Gavi countries. Now, part of this is, of course, due to the changing birth rates, which is why we initially examined the rates per 100,000. However, this does show that this is a persistent problem. And numerically, this becomes a much bigger issue, because what we're saying is that in 2022, there was approximately 280,000 perinatal infections of hepatitis B. Now, if we assume that 20 to 30% of these will go on to die of early preventable deaths as a result of hepatitis B liver complications, this is 70,000 deaths that will occur just as a result of the infections that occurred in 2022. Now, what we did is we compared to the Gavi countries that did implement the birth dose. And if non-birth dose Gavi countries had been supported and met similar levels of birth dose intervention as the Gavi birth dose countries, we estimate that 62% of these deaths could have been prevented. So I would like to leave with one very positive note, which is, of course, the global efforts to reduce the incidence of hepatitis B have been absolutely phenomenal and have really seen astonishing results and reductions. However, the lack of timely birth dose support in Gavi countries has exacerbated what we know were the pre-existing disparities to what are really extreme levels. Every single year that programmatic support is delayed could result in over 70,000 early deaths from a very preventable disease. We need immediate support for timely birth dose, particularly in countries, low-income countries and those within Africa and Oceania. And we need to relax the treatment criteria for pregnant women so that we can meet countries where their current capabilities are at while we work with them to build and strengthen their community, their capabilities and their public health responses. If we do this, we truly can eliminate the perinatal incidence of hepatitis B and make this a problem of past generations. I thank you for your time, and I look forward to your questions in our discussion.
Thank you very much, Devin, for your presentation. On the numbers speak for itself. And also based on your presentation, I would also want to let you know that for anyone who is in Geneva this week, please join us in Geneva to show the support for the millions of babies infected with hepatitis B at birth in gathering in front of Gavi's office in Geneva. So if you are around and you want more information about that gathering, please come and ask any of our WHA staff, and we are happy to share more information with you. And now I would like to introduce our next speaker, Chuameka. Sorry if I don't pronounce it. From Clinton, from Chai in Nigeria. So Chuameka is a public health officer passionate about saving lives and improving health outcomes, with over 12 years experience across the public health and private sector and in sales and marketing and management consulting and project management. So he currently leads the hepatitis program at Chai, Nigeria. And his presentation is about birth dose vaccine coverage and barriers to timely uptake in Nasarawa and Kanto states in Nigeria. So over to you. Thank you.
Good morning, good afternoon, good evening, depending on where you are around the world. Once again, welcome to this summit. In the next few minutes, we'll be looking at a study done here in Nigeria, which looks at the birth dose vaccines coverage and barriers to timely uptake in Nasarawa and Kano states. My name is Chukwemeka Agbocha, and I currently lead the Nigeria Hepatitis Program at Clinton Health Access Initiative. We begin by looking at the Nigerian immunization landscape with a focus on the policy framework and existing gaps which led to this study, the results, and lessons learned. Routine immunization prevents over 5 million deaths globally. However, a little below 20 million children miss these key vaccinations. The picture is not very different from what we have here in Nigeria, where an estimated 31% of children below 2 years of age receive all basic vaccinations. Now, these gaps could be linked to weak health systems, out of facility deliveries, poor vaccine supply chain and security, limited health workforce, and other factors. The birth dose vaccines which we're speaking about are 3 in number, which are the BCG, the OPV, and HBV, and they should be given within 24 hours of birth. While we can see from the chart in the middle, over 50% coverage in the birth dose vaccines, it doesn't reflect a true picture for 24-hour timely coverage as recommended by the World Health Organization. The National Program for Immunization provides a 2-week window for administering these birth dose vaccines. The initial thinking behind this approach was to accommodate deliveries after work hours, over the weekend, and outside of the facility. However, this approach has led to a lot of missed opportunities, taking into cognizance our weak service delivery system, and not ruling out other constraints such as poor healthcare knowledge and limited caregiver awareness on the need for these birth dose vaccines. Now, putting these gaps together, what this means is there's a likelihood of over 70% of our newborns who miss these birth dose vaccines to run a risk of being infected with hepatitis B virus. And from this cohort, under 25% are at risk of premature deaths. To address these gaps, the study, which is aimed at assessing the impact of integrating RI services into maternal and newborn care at the health facilities could change, and how it could change timely coverage of birth dose vaccines, was done in Nasarawa and Kano states in 18 facilities. The study had 4 components, starting with a baseline assessment, which seeks to understand the current situation on the ground, and then using a human-centered design, having relevant stakeholders around the table, including the pregnant mothers and breastfeeding mothers. We explored a bottom-up approach, designing interventions which are tailored to the respective facilities across the 2 states. The outcomes of this study showed that not less than 100% increase was recorded in coverage of timely birth dose vaccines across the 2 states and across the 3 birth dose vaccines. But it's important to draw the attention to hepatitis B vaccine. We've recorded a tremendous increase, not less than 150% in both states. This could be linked to task shifting to the maternal unit of the facilities. To also look at the weekend deliveries, as I mentioned earlier, which was a key gap, we had a deep dive to really understand the impact over the weekends, and we saw not less than 50% increase in coverage. Now, this could be attributed to improved access to vaccines, even in the absence of the RI officer. From a qualitative perspective, we can see tremendous increase in healthcare worker knowledge and practices on the chart. But then again, if you look closely at the first bar, you would see a 50% increase in the need to administer this birth dose vaccines. And this could be likened to the earlier results which we saw in the presentation. So what did we learn? In addition to the points earlier mentioned, integrating HBV messaging into routine ANC sessions was key to increasing awareness and demand on the caregiver side. Now, deploying the geostars helped eliminate infrastructural gaps and also vaccine supply chain challenges, while the peer mentoring approach was crucial to improving healthcare worker capacity and also knowledge retention at the facilities. Our recommendations build up directly from the lessons learned, which informs broader scale-up. This includes improved vaccine supply security and infrastructure, especially in areas that lack solar refrigerators. Integrating the birth dose administration strategy into newborn care packages is also very important. At the policy level, incorporating the task sharing piece in the MNCH guidelines is key to ensure that the L&D workers have requisite capacity to provide RI services. Now, looking at these interventions and also other global interventions being piloted, this could provide that synergy needed to catalyze efforts towards achieving hepatitis B free generation and ultimately elimination. Thank you so much. I'm happy to take your questions.
Thank you very much, Chukwuemeka, and we see you. You are online as well, so very happy to have you. Please have any questions that you may have for Chukwuemeka, put them in the chat or have them ready so that during the question and answer period, he could answer for you. I think his presentation really has shown us that immunization is very important intervention, but the timeliness of birth dose is even more critical. And these innovations are the answer with the needed mind shift. And really, our care providers need to change the way we do things to make sure that we do have the effect that is needed if we really want to eliminate mother-to-child transmission. So the next speaker who I'll be inviting will be Nafisa Yusuf, who will be talking to us on how mothers with chronic hepatitis B understand and experience PMTCT interventions in Victoria, in Australia. Now, Nafisa is a social researcher at the WHO Collaborating Center for Viral Hepatitis, and she is passionate about health equity and improving the lives of people who are affected by hepatitis B. Nafisa, over to you.
Thank you, Marco, and thank you, everyone. Hello, everyone, from wherever you're joining from. It's midnight for me here in Australia, so I'll try to keep going. But before I start, I would like to acknowledge the traditional owners on the lands on which we're all in and calling from, and pay my respects to their elders, past, present, and future, and any Indigenous people in the audience. I have no conflict of interest. So today I'll be giving you a quick overview of this study and discuss key results and opportunities before moving on to Q&A. So these are community co-designed qualitative research study aimed to explore how mothers with hepatitis B understand and experience PMTCT, the prevention of mother-to-child transmission. And I'd like to acknowledge that this is part of a larger study. So in Australia, there are about 230 people living with hepatitis B, and in the state that I'm in Victoria, there are about 800 women with chronic hepatitis B who give birth every year. We know there is evidence of local mother-to-child transmission, both in this state and also across the country. We also have heard from previous previous speakers, and we know it's globally established that children who are exposed to hepatitis B perinatally have a higher risk of developing chronic hepatitis B as adults. Mother-child transmission is a key priority. We know through that, through the triple elimination, but also part of our local and national hepatitis B strategies here in Australia. We interviewed 16 women with chronic hepatitis B. As you can see, 11 of those were from the Asian region, 5 from Africa. 7 of the women required an interpreter, and 12 of the women had either primary or secondary education. The key results were that women were diagnosed at a really complex stages of their life, either during pre or post-migration to Australia, or during antenatal screening. As you can imagine, it's a really stressful time for women to be diagnosed with a chronic condition. There was little to no formal information provided to women. As Fadime here describes that she was tested at each pregnancy, but healthcare providers didn't really get involved in her hepatitis B, and there was not much information provided to her. There was also educational gaps in the healthcare providers, with women, as Amala here was advised not to, give me a second. Sorry, this is when your children wake up in the middle of the night. And as Amala here says, even with the interpreter, she doesn't really understand what information was provided to her. Understanding of vaccination and transmission varied among women. So most women had a basic understanding of the principles of vaccination, but some women didn't really understand what that all meant in terms of practically. So Fatih here talks about, she's concerned that she misunderstood the heel prick testing for hepatitis B testing. So in her mind, her baby was actually tested for hepatitis B during birth, which obviously we know that it might have been a vaccination or something else. So it shows that there's really a lack of understanding about vaccination. Amala here was also advised not to breastfeed within 24 hours of giving birth, which of course we know it is safe to breastfeed with chronic hepatitis B. There were huge concerns about mother-child transmission and liver cancer. As Thoda here explains that her and her husband have hepatitis B, and she's really concerned about passing that on to her children. And I think this was even really common, even with women who their children and their family were vaccinated, they were still really concerned about transmission, and they were really concerned about sharing personal items. Fatih here also discussed another theme that came across about intergenerational impact of hepatitis B. As she says, she knows she's seen people and friends and family die of this disease. There were also poor social and emotional support for women. A lot of the women expressed that the focus was so much on the baby and not on the mother. Additionally, there were no relevant hepatitis B and pregnancy resources for mothers. So where do we go from here? So I think to improve care for mothers with hepatitis B and to address hepatitis B in an equitable approach, we really need to strengthen our systems and take a system coordination, including coordinated care delivery implementation protocols. We know there are endless guidelines for hepatitis B management, but what we really need is a standardized protocol for implementation. We really do need community education and support through community engagement and peer-to-peer support. We've seen this and across other studies that workforce education is another area that we really need to focus to improve care for mothers with Hep B and their families. Additionally, appropriate hepatitis B resources and hepatitis B and pregnancy resources was also another gap that we really need to address. And finally, following up children born with hepatitis B to ensure that they are vaccinated, but also that if they do have hepatitis B, that they are receiving appropriate care. Thank you. Thanks to my team and co-investigators, project partners, and the Victorian Department of Health for funding, and importantly, mothers with hepatitis B who have participated in the study and also who were part of the advisory group. Thank you.
Thank you very much, Nafisa. I just checked the work clock and realized that it's actually 1:30 a.m. Melbourne time. So great job. So I want to introduce our next speaker, Professor Yashir Wahid from the Foundation University, Islamabad, Pakistan. And he will talk about familial clustering of hepatitis C in the Pakistani population.
Prevention of mother-to-child transmission and hepatitis B vaccination of children in Bangladesh. We know majority of Hep B transmit through the vertical transmission from mother to child, and also in horizontal, in community-based in early childhood. When infected at 6 months of age or at birth, 85 to 90% chance of getting chronic hepatitis, liver cirrhosis, and liver cancer. Prevention of mother-to-child transmission and birth dose, childhood vaccination, catch-up vaccinations are the basics to control hepatitis B infection. In Bangladesh, there is 166 million people, and 49%, more than 49% are female, and 62% total births occur at household levels. Hep B infections occurs about 5.5% of the general population and 3.5% of the pregnant women. Majority people in rural Bangladesh are not aware about viral hepatitis and its consequences. National Liver Foundation of Bangladesh conducted awareness of pre and hepatitis B testing of 1,130 pregnant women in December 2010, and NoHep campaign among 300 pregnant Rohingya refugees at Cox's Bazar in 2017, and free testing and vaccination done at 6,360 children from 2007 to 2021 in the government children homes, baby homes, and orphanages, blind, dumb and blind schools, and SOSB villages. And study showed that among 1,030 pregnant women, 2.5% having hepatitis B. Among 300 pregnant Rohingyas has 3% hepatitis B. And 6,000 children shows 2.5% having hepatitis B. These are some pictures of this screening programs. And this is the one for Rohingya refugees. And this is the children vaccination throughout the nation. And this is the last one we conducted in November 2021. And this is the nationwide viral hepatitis awareness campaign and vaccination campaign which we are conducting. And we also, NLFP initiated PMTCT in Bangladesh with the engagement of multiple stakeholders and societies like gynecologists, obstetricians, hepatologists, organizations dealing with women and children. Aim to convey the message of the PMTCT to the unreachable community of the country by their countrywide network, and advocacy made to the government for making a PMTCT control strategy and birth dose implementation. PMTCT poster and brochure placed in public places, both in English and Bangla. And Bangladesh Medical Student Society took the initiative to pass the messages through its different branches throughout the medical college of the country. And this is the initiation of the PMTCT in Bangladesh with multiple stakeholders like obstetrics, gynecology, Society of Gastroenterology and Hepatology, Society of UNFP, Hepatology Society Bangladesh, BRAC, Meristos, and BMSS. And this is the webinar initiation, which we initiated the PMTC, and this is the brochure in English and Bangla. And this is the Nohab Mom's brochure, poster, which we popularized throughout the nation. And this is the BRAC, which took the initiative to pass the message throughout the nation, because BRAC is the largest non-government organization which has got the branches in 64 districts. And they are conveying the message of the PMTC to their branches throughout the nation. And this is Mary Stops also came forward and also passing the message to their branches throughout the whole nation. And BMSS, Bangladesh Medical Student Society, also passing the message to everyone. This is their conveying message. And we also came to the social media, social Facebooks and Twitters. Hep B control starts at birth, and PMTCT Hep B childhood vaccination plays pivotal role to reach the goal of 0.1% LOR of 5 children 5 years by 2030. Gynecologists and obstetricians should play the vital role, because Hep B passes from mother to child during their care of pregnant women. Women and children organizations has got the impact of PMTC and children vaccination. Mass awareness on vaccination in mothers plays the important role. Implementation of PMTCT, birth dose and childhood vaccination should be the goal. Together we can achieve the goals. Thank you, everybody.
Thank you very much, Professor. He's actually just sitting opposite me. And yeah, and that's so great to see him, and then also seeing his pre-recorded video. Although I really need to go through the questions that we received during the session, but because we are really, we really late in time, and there's also other sessions going, lining up. So I just have to say that we won't have any Q&A session. But if anyone having any questions, then please just reach out, and then I think we can contact the speakers and give you the answers to you as well. I guess what I just want to say as the co-chair of the session is that so we have heard stories and numbers around the world about prevention of mother-to-child transmission. And as a mother living with hepatitis B myself, and also representing people living with hepatitis B in the Western Pacific region where it is the most prevalent. So all the stories and all the numbers are so vivid that brings a lot of emotion. So there's some happiness when seeing there's actually some ways to improve the things, but that's enormous pain and hurt when seeing still there when I saw that there's actually the numbers and stories telling about how mothers and their infants are not receiving care, like minimum care, when they are actually the most vulnerable in their lives, both physically and mentally. So but I'm still like, I'm positive and thinking about like how lucky some of us have been to have our children free from hepatitis B from us. So I'm confident that as long as we can actually get commitment and get the voice up and get on the policy makers in, and then we have the commitment, we will be able to get there. So I guess there's I just want to say thank you, everyone. Thank you, Nafisa, for being here at 2 a.m. and thank you, everyone from different part of the world. I cannot check what time you are in, but yeah, but great to see you, and hope to be able to hear about your success stories more in the next summit in 2 years. And so I would like to close our session. But before I actually close the session, I just want, I have a note to make. So please stay online and join us for a symposium on the impact of stigma and discrimination affecting people living with hepatitis B. For those of you in Geneva, we will be streaming this in the Kofi Annan room on the ground floor. So thank you very much. Please join us. I have to jump to that symposium now. So if you want to see me again, please join me as well. Thank you very much, everyone.
Thank you.
Thanks, everyone. Bye.